Hi there. I'm so excited to welcome you to the Arthritis Life podcast, where we share arthritis life stories and tips for thriving with autoimmune arthritis. My name is Cheryl Crow, and I am passionate about helping people navigate real life with arthritis beyond joint pain. I've been living with rheumatoid arthritis for 20 years, and I'm also a mom, occupational therapist, video creator, support group leader, and I created the Room to Thrive self-management program. I am so excited to help you live a more empowered life with arthritis. We're going to cover everything from kitchen life hacks to navigating the healthcare system to coping with friends who just don't get it. Seriously, no topic is going to be off limits on this podcast. My interviewees and I share our honest stories of how chronic illness affects our lives. This includes discussions about mental health, sex, shame, pregnancy, body image, advocacy, self-acceptance, and so much more. You'll hear stories from all ends of the spectrum, from a person who's living in medicated remission from psoriatic arthritis to somebody living with severe mobility restrictions and severe pain from rheumatoid arthritis. You'll hear how people manage their conditions in different ways, like medications, mindfulness, movement, social support, work accommodations, and so much more. You'll also hear from rheumatology experts who just get it. We'll dive deep into the science behind chronic pain and what's the latest evidence for lifestyle changes that can help you thrive with arthritis, including exercise, sleep, nutrition, stress reduction, and more. This is your chance to sit down and chat with a friend who's been there. Ready to figure out how to manage your arthritis life? Let's get started.
Welcome to Rheumer Has It, the podcast that busts myths, highlights evidence, and inspires hope for living better with rheumatic disease.
Through plain language interviews with experts, we offer actual knowledge so you can thrive today.
My name is Eileen.
And my name is Cheryl.
Join us as we bust myths and spotlight evidence. Disclaimer to this episode today. It is not an episode to shame anyone about their body weight, and we know this can be a very sensitive topic. Our goal with this episode is to educate people on how and why weight management can improve rheumatic diseases and our quality of life. Weight is different for everyone. I personally have struggled with my weight for a number of my years. But when I did lose 60 pounds, I felt my best because it improved my pain, my sleep, mental health. Now, unfortunately, with medications, it's been a bit bumpy and kind of difficult to manage keeping a healthy weight when living with a rheumatic disease for a variety of reasons, which we'll go on about. But today we have a very special guest who I have personally the honor to work with a number of times with Arthritis Research Canada. And I've also seen him win some nice awards during some of the rheumatology research conferences, which is very exciting. So congratulations for all that you have accomplished. I'm happy to introduce Dr. Darren Caracabelli here to talk about weight and arthritis. Now, can you let us know a little bit about your training and how you came to specialize in this topic?
Of course. Thanks, Eileen, and thanks for having me on the podcast. So I'm a rheumatologist, and I'm also certified in obesity medicine. I started off my undergrad studies in kinesiology at UBC, and then did all my medical training at UBC. And then through the American Board of Obesity Medicine, there's a certification pathway where you can do some additional training, take some additional courses to become more knowledgeable about how to manage obesity. And so I did that because I thought it would complement my ability to help patients with arthritis and extra body weight manage the other piece, the obesity piece. I also do research in the intersection of metabolic diseases like diabetes and obesity with inflammatory arthritis. So a lot of my work is in looking at GLP-1 receptor agonists. I'm currently doing a PhD on that topic.
That's incredible. And I didn't know until recently that there were doctors that could become, did you call it a certification in obesity? Yeah.
That's right. Yeah.
Okay. Yeah, that's great for people to know because I was been just personally like on a kind of a smaller frame, and I haven't had, my actual only struggle with weight was muscle loss. Like one of my first symptoms when I didn't know I had rheumatoid arthritis yet was unintended weight loss and muscle loss from rheumatoid cachexia and sarcopenia. But I know other people struggle more on the other side, or maybe they have a bit of both, weight gain in some areas and then muscle loss. So long way of saying Can you explain a little bit, just an overview, bird's eye view, how arthritis affects weight? What's the spectrum here?
If you have ever felt completely lost or utterly alone while trying to navigate real life with rheumatic disease, listen up. I am here for you. I created an educational program to help you go from overwhelmed to confident, supported, and connected in a matter of weeks. And it's called Room to Thrive. After earning a master's in occupational therapy and completing hundreds of hours of additional training, I created a step-by-step guide to help you truly thrive with rheumatic disease. This is the only program I know of that's designed to improve quality of life for people living with inflammatory, autoimmune forms of arthritis, like rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, non-radiographic axial spondyloarthritis, Sjogren's disease, and more. During the self-paced lessons, you'll learn how to manage pain and fatigue, cope with stress, navigate relationships, and continue doing the things that matter to you and bring you joy. The goal is really to help you improve your quality of life and learn how to thrive with your rheumatic disease right now, rather than waiting for a distant day when it might be cured or healed. I really created the down-to-earth, practical, heartfelt resource I wish I had had when I was first diagnosed at age 20. If you want even more in-depth support, you can join the 12-week Room to Thrive virtual support group, where you'll be surrounded by people who actually get what you're going through, people who will provide the encouragement, validation, and support that you deserve. Each group is expertly moderated, so you don't have to worry about the kind of misinformation that spreads like wildfire in the free-for-all social media groups. If you're on the fence, don't just take my word for it. Here's what Katie had to say in March 2023. I was lost and overwhelmed with my RA diagnosis. It felt overwhelming to know what to read, what to do, how to spend my energy trying to research on the internet. Room to Thrive did that for me. It's been like getting a crash course in my diagnosis along with a community who gets it. To see all the details, including the dates for the next support groups, go to the link in the show notes or bit.ly/thrive-room with a capital T and capital R. You can also just email me anytime at info@myarthritislife.net. And don't delay if you're interested, because each group is capped at 16 people or less in order to make a small, intimate group atmosphere. Thanks so much for your time, and I can't wait to get started with the next groups. And I can't wait for those of you who are interested in the self-paced option to go ahead and join that at any time. Bye-bye for now.
You bring up an excellent point, Cheryl. So I think it really depends on the person. Some people lose weight, some people no effect on their weight, and a lot of people do gain weight. So quickly touching on the point that you mentioned, having an inflammatory type of arthritis like rheumatoid arthritis, that systemic inflammation itself can lead to muscle loss and weight loss. So especially in the early phases before you get on effective therapies, that can totally happen. On the other end of the spectrum, is weight gain. And so Eileen alluded to this, at the very beginning when she said that some of the medications that are used to manage inflammation in arthritis, things like prednisone, those can promote weight gain. And then on top of that, when you get diagnosed with arthritis, it can be life-changing. It can affect your ability to sustain certain behaviors that were perhaps helping you maintain your weight. And so if you're no longer able to continue with certain amounts of physical activity, or if now there are barriers, functional and pain barriers to grocery shopping or meal prepping, and if there are effects on your mental health or your sleep, all of these things could impact behaviors and hormones that affect body weight regulation. And so it can be complicated, but it's common and totally understandable why some people gain weight, why others lose weight, and for some, the weight stays the same. Is that, I know it's a bit of a wishy-washy answer.
No, I think you painted, to me at least, a really great picture of a really clear picture of the spectrum. And honestly, I actually didn't even know that my weight loss related to my rheumatoid arthritis until 6 years after my diagnosis. And I just think one of our goals, Eileen and I's goals in doing this, is just helping people know earlier along in their journey. They tend to be educated on like the joint stuff, but not the extra articular manifestations. So this is really helpful. So I'll let Eileen ask the next question.
Yeah. And, you brought up a lot of great points there. And I will add that weight can fluctuate for so many different reasons throughout our journey, especially depending on what age we're diagnosed as well. So I actually did experience some of the muscle loss and the weight loss at the beginning of my diagnosis when it was really bad. And I didn't have effective treatment. And it has shifted throughout my patient journey, depending on medications. I have 2 forms of rheumatic disease now, rheumatoid arthritis and non-radiographic axial spondyloarthritis. So those gaps in finding effective treatment can also be a place where physical activity is not as easy. So you brought up a lot of key points that are very unique to somebody living with a rheumatic disease and why we struggle with the typical exercise plan and meal plan that maybe somebody who isn't experiencing what we are experiencing symptom-wise and all it takes to manage living with a rheumatic disease, because it takes time as well. It can interrupt our sleep a lot. So all these things really do impact how we can manage our weight. But now that we have talked about what can impact us, we got to talk about why we need to talk about this subject. So why does excess body weight consisting of adipose tissue, aka fat, have a negative impact on people living with all forms of arthritis, not just inflammatory, but let's say osteoarthritis as well?
So it's interesting because our understanding of adipose tissue or fat tissue has evolved quite a bit over the years. And in the past, we used to think that fat tissue was just benign. It was just extra weight, and the extra weight itself would increase the mechanical load on joints like the knees, on weight-bearing joints. That's what we used to think. Your arthritis was perhaps worse if you had obesity because there was more load on joints like the knees or the hips. But over time, what we've learned is that excess adipose tissue or excess fat tissue, especially in certain areas of the body, can actually generate inflammation itself. So it can be inflammatory. We call it metabolically active tissue. And so when you already have a disease that's affecting your joints and there's inflammation in those joints, and even osteoarthritis, which traditionally was thought of as a non-inflammatory type of arthritis, we now recognize that there is some low-grade inflammation in osteoarthritis as well. And so the extra inflammation that comes from having extra body fat can make all forms of arthritis worse. And so what we know from osteoarthritis is it's a combination of those mechanical factors, the increased load, but also the inflammation from the obesity itself that can make the arthritis worse, the pain worse. And an inflammatory arthritis like rheumatoid arthritis, you mentioned axial spondyloarthritis, and the other one is psoriatic arthritis. We know in all 3 of these types of arthritis, people who have obesity often have more active disease. And also their disease is harder to manage with existing therapies. They don't respond as well to some of our commonly used therapies like TNF inhibitors. So those are some of the reasons why I think trying to facilitate the management of extra body weight or extra body fat, I should say, is so important for people with rheumatic diseases, because we've seen from some research that people who are able to lose a healthy amount of weight, whether that be through diet or surgery, or some of the newer studies are showing through medications, people tend to feel better. Their pain tends to get better. Their function tends to improve. Not for everybody, but for a lot of people.
Thank you for that. And I wanted to add a little additional disclaimer that I think it's important, at least for me as like a patient and a practitioner, to separate the idea of like fatness as a social construct, the word fat or people being overweight as like a label that gets put on people, versus the physical reality of adipose tissue being a physical thing that's in people's bodies. I believe everyone should be accepted and loved, in whatever body size they have. And we have to hold that perspective alongside the perspective that our bodies are physical things made up of physical tissue. The other thing I remember learning as an occupational therapist is like every 10 pounds you are overweight increases the force on the knee joint by 30 to 60 pounds per step, just from like that mechanical standpoint. So sometimes the reason people feel better when they lose weight is they're literally just loading the joint a little less.
I've heard similar statistics, about the mechanical load, as you said.
Yeah, I'll let Eileen do the next question.
Yes, I have also heard similar statistics to that as well. And from my own personal experience, when I was regularly in the gym at my healthiest weight, I was more active. I didn't have as much pain. I was able to get more steps in the day without pain coming, sooner in the day. So you notice little things like that, and less knee pain as well. And you sleep better through the night. So there's so many reasons why being a healthy weight is important, but also so many reasons it's challenging when we live with arthritis. So we're going to move on to one of the myths around weight, and that is that the body mass index, BMI as it's also known, is the best way to measure what a person's healthy weight is.
Okay. Yeah, I think I'm glad we're starting with this one because I think this comes up a lot. So I think it's important just to start with what is the body mass index. So body mass index is simply a ratio of your weight over your height squared. So the only two things that go into calculating a person's body mass index is their weight and their height. And so all it can really tell us is how much you weigh for how tall you are, so to speak. And then essentially based on references that were developed from healthy white European men, we have these cutoffs that we use to determine whether somebody is underweight, normal weight, overweight, or have obesity. And on a population scale, the BMI is actually a helpful tool because it's quick. It can be easily calculated. It can give us a quick snapshot of, how somebody's weight compares to their height. But there are a number of limitations to it, especially for a person or a patient standing right in front of you. One is that it doesn't give you an idea of what that weight's coming from. So it doesn't tell you how much of that is adipose tissue or fat tissue, how much of that is muscle tissue. It also doesn't tell you where that adipose tissue might be. So depending on where a person carries their extra fat tissue, some areas are less harmful than others. Some areas are healthier than others, less metabolically active. And then, like I said earlier, the cutoffs that were initially developed for BMI were based on a single population that's not representative of our diverse world. And so applying BMI cutoffs are not always applicable to people of different backgrounds. And so actually different BMI cutoffs are sometimes used now for different populations as well. And also I should mention that for people with, like, for example, rheumatoid arthritis, as Cheryl was mentioning, when you have that sarcopenia or rheumatoid cachexia, because there is that preferential loss of muscle, there's an argument to be made for maybe using different BMI cutoffs, perhaps lower BMI cutoffs, because people have less muscle as well. But all this to say, it's still a helpful, quick screen, but it's not a great tool for the person in front of you always.
Thank you. That's really helpful. The next stigma we wanted to go over is that people with arthritis are lazy and that's why they're overweight, or that it's totally your fault if you're overweight. It's not like a disease or anything. And we want to recognize that there really is a mental health impact of these sort of societal stigmas around this. What would you say? Maybe how do you help your patients work through that?
Oh, 100%. I'm so glad you brought this up. I think, unfortunately, there still is a lot of stigma, not only in general public, but even in healthcare, there's still a lot of stigma. There's a lot of shaming people and kind of blaming extra weight as if it's like a willpower deficiency or as if it's a choice that you're making, which I just think is, well, number one, I just don't think it's helpful. And number two, I don't think it's fair. We know that based on genetic studies, the proportion of one's weight that's inherited, the numbers fluctuate, but anywhere from 20 to 70% of body weight is said to be inherited or genetic. So a big chunk of where your weight ends up settling is determined by your genes, which you don't have control over. And then the other component is the environment within which you live also has a huge impact on the choices that you're able to make. Like if you're living in a place that doesn't have healthy access to foods or isn't walkable or isn't safe, like that's going to steer you to certain behaviors that might not be as conducive to maintaining a healthy weight, but that's also not your fault. That's a product of where you live and your circumstances. So again, blaming people is just not helpful. Trying to help people navigate these challenging situations, I think, is helpful. And so I try to tell people that it is not your fault. And if people have told you it's your fault, I'm sorry on behalf of them. I think what's more helpful is understanding where a person's at, how we can help them where they're at. But again, kind of thinking upstream and recognizing that these aren't, this is not all a matter of choice. And I guess in terms of arthritis, people who have arthritis are lazy. Again, I don't think it's fair because, again, a lot of like arthritis often just develops out of the blue, like for a lot of people, especially if it's, inflammatory arthritis or even osteoarthritis. Again, like there are a number of risk factors, but there's a lot of things that are outside of a person's control. And then once you develop this disease, it becomes a lot harder to address the underlying factors. So it becomes this cycle that's really hard to get out of. And the last thing I'll mention is that now many international bodies recognize obesity as a chronic disease, similar to diabetes or high blood pressure. And so, like when we look at diabetes and high blood pressure, we know that there are lifestyle factors that certainly help, like a healthy diet, physical activity can help manage your blood sugars, or they can help with your blood pressure. But like when somebody has diabetes and they've done their best at being physically active and eating a healthy diet, if their sugars are still high, we don't say walk more or like cut your sugar more. If your blood pressure's high, like cut your salt even more. There's a stage where we say, okay, you've done your best with kind of these foundational principles. Now let's look to add on therapies that might help you achieve your goals. So we see obesity, at least I see obesity a similar way. And that's how a lot of my colleagues in obesity medicine see obesity as well.
That's really helpful. Thank you.
Yes. Many valid points there. Thank you. And also thank you for recognizing that it's so much more than just being overweight. All right. So we are going to move on to another myth. And this one is about movement. If your joints hurt, you shouldn't exercise because that'll just cause more wear and tear or inflammation on your joints, or it's just going to make your fatigue worse and your cognitive dysfunction worse. It's just going to make you feel worse. Is there any truth behind that?
So yeah, this is nuanced for sure. So what we know is that generally speaking, if people are able to gradually introduce physical activity in perhaps a supervised way or in a guided way, generally speaking, physical activity helps people feel better. They have less pain and energy levels, sleep, all these other factors, mental health, cardiovascular health, like heart health. All of these things tend to improve with physical activity. The notion of exercise causing more wear and tear, we've tried to move away from labeling things like osteoarthritis as a wear and tear disease, because again, we know that physical activity generally actually slows progression, makes people feel better. There is some truth to the statement in that if you exercise too much, or if you do too much too soon, or if you do very high intensity exercise and your body's not ready for it, that can lead to injury, and injury can accelerate, for example, osteoarthritis. Like if you have like an ACL tear, that can accelerate osteoarthritis and things of that nature. Generally, for most people, if exercise can be done safely in small amounts, approved by, a certified professional, I encourage that. I think that is the benefits far outweigh the risks. I just think the key to it is tailored for the person.
I would just like to add that is so true. I have had the same physiotherapist for a number of years now, and I keep him because throughout my patient journey, my disease changes, and I will need to say, "Hey, I have a new autoimmune disease. It's in my back, so let's go over my exercise routine and tell me which exercises are not good for me to do now that I have, some more answers to what's going on in my body." So I want to emphasize how important having that tailor exercise program for your unique needs, where your arthritis is, what types of arthritis you have, what types of comorbidities you have is so important. And then also how they can help you with adjusting behaviors throughout the day that you can, get more little exercise snacks and things throughout. So just wanted to make a comment on it. I'm going to pass it on to Cheryl though.
No, that's perfect. But another thing that is a huge hot topic, I think, Eileen, wasn't this like you wrote a blog about this and it was like your most looked at one or one of your most looked at, the GLP?
Yeah, actually, and I interviewed her in it, or that was on obesity for a campaign, but I disseminated the most recent ACR 2025 abstracts on GLP-1s, and it was definitely my most read blog, most social media engagement. So And it is also a topic that I am consistently daily seeing in a lot of the groups and either Facebook, Instagram, and I've hear people all over. And then I also like when I'm in the fitness groups too, I see a lot of shame against the medications. So it's very, very interesting. So I'm gonna move this over to Cheryl because she's about to ask a very, very important question.
Yeah, like a misconception is that the GLP-1 kinds of weight loss medications are just for people with diabetes and not really for arthritis. Or maybe there's a little stigma that they're for people who want to take the easy route. Can you help us understand what is the role potentially of this class of medications in arthritis care?
Sure. I guess I'll start by saying that the way that I see the GLP-1 receptor agonist class, I'll just call them GLP-1 medicines so it's easier. But the way I see GLP-1 medicines, I see them like a tool in a doctor's toolkit or in a patient's toolkit. And they can be a very effective tool. So we know that they manage diabetes really well. You alluded to their use in diabetes. So they were originally developed as diabetes drugs, and they're still used for diabetes. They are also approved for use in obesity. And they've also been shown in people who have obesity with certain other conditions. So, for example, if you have obesity with high risk of cardiovascular disease or high risk of having heart attacks and strokes and things of that nature, these medications have been shown in that population to reduce the risk of having those serious events, heart attacks, strokes, death from cardiovascular causes. And then more recently, it's been shown that in people who have obesity and osteoarthritis, adding a GLP-1 receptor agonist, the one that they studied in that study was semaglutide, which is also known as Ozempic or Wegovy. When people received semaglutide versus placebo or sham treatment, those who got the GLP-1, they experienced a lot more weight loss, but they also experienced a lot more improvements to pain and function. And these were all people with at least moderate knee osteoarthritis. So that was a very exciting finding. And a lot of people, there haven't been a lot of effective medical therapies for osteoarthritis. And again, it's important to stress that this was in a group of patients who had obesity. And actually, the average BMI in that trial was around 40. So these are people who had kind of more severe forms of obesity. Nonetheless, these people benefited a lot from having that treatment. So I suspect that moving forward, there will be a lot more interest and adoption of using GLP-1s for people with both obesity and osteoarthritis. There was also a study that it's finished, but the full study hasn't come out yet. It looked at coupling tirzepatide, which is also known as Mounjaro or Zepbound. It's a GLP-1 plus GIP coagonist. They looked at coupling that medication with a biologic for psoriatic arthritis. And again, they found that when you got the couple, people lost more weight and had more improvement in their joints, versus if you just got the biologic alone, you didn't lose as much weight, your joints didn't improve quite as much. We haven't seen the full results of the study, but again, the top line results are pretty encouraging. Coming back to, I guess, the original question around their role, I would say right now, we know they have a role in people who have diabetes, and we know they have a role in people who have obesity or who have extra body fat, who have, I would call it excess cardiovascular risk or extra risk factors for heart health. Seems like it improves outcomes for those people. For people who don't meet those conditions, there still needs to be more research into their role. But generally speaking, again, I think coming back to my original point about like obesity being a chronic disease, like I don't think it's kind to people to make them feel shame about using these medications or taking the easy way out, so to speak, because often the people who are exploring these medications who are trying to manage their weight have worked super hard and haven't taken the easy way out. They've tried often multiple types of diets. They've often tried several different physical activity programs and cycled through different things. And often they just haven't quite achieved the results they do with those interventions alone. And sometimes a GLP-1 can be something that you add on to the existing nutrition practices or physical activity practices that you're doing. And in combo, that gets you to your goals. The final point I'll say, and then I'll pass it back, in these trials that studied obesity in people, again, on like semaglutide or tirzepatide, in these studies, they're always paired with, usually at the beginning of the studies, it's like monthly check-ins with a dietitian or a registered exercise professional to talk about nutrition, to talk about physical activity. And so people are doing both. Like I find that there's often this narrative of it's GLP-1 or exercise diet. But like what I try and tell people is it's GLP-1 and exercise and diet. I think that exercise, nutrition, that forms the pillar, the foundation. And then on top of it, we could add things if needed. That's kind of how I see it and explain it to people.
Absolutely. And you actually just alluded to our next topic, which was other than exercise, what are some lifestyle and therapeutic changes, including other medications than GLP-1s, that can improve weight management for people living with arthritis?
Sure. So the way I kind of see obesity management, and this is kind of what I learned through some of my extra training, is I kind of see it as a pyramid. So at the base of the pyramid are your behavioral interventions, things like physical activity, nutrition, optimizing sleep, optimizing stress levels, making sure you have healthy social connections. So that's the foundation. And again, it can be really helpful to get support with those things. So we talked about occupational therapy, physiotherapy, registered dietitian, social worker, therapist, like all of these people can be really helpful for that kind of base layer. And then when people can't achieve their goals with those interventions alone, we can look to adding medications onto that. So we talked about the GLP-1 medicines already. There are other drug classes that can help people with weight loss. Again, it depends a little bit on one's underlying conditions and what medication is the best fit for them. So I would say talk to your doctor about that. Another common one that it's not used as commonly anymore. I find that right now it seems like GLP-1 medicines have kind of become the most used therapies for obesity, but other ones, like another one that's commonly used is naltrexone bupropion. It's a combination of two medications. That one can also be used. That typically leads to weight loss in the realm of around 5-ish%. Whereas with the newer GLP-1s, kind of we see weight loss 15%. So the responses with these newer GLP-1 medicines is larger than we've seen with previous obesity therapies. And I think that's why one of the reasons why they've gained popularity. The other is that they've shown these benefits for heart health and now for kidney health in people with diabetes. So that's also exciting. But again, having a discussion with your doctor is important because these medicines aren't for everyone. There are side effects, there can be contraindications. So I do think it's still, again, an individualized decision. And the very top of the pyramid for certain people is things like bariatric surgery.
No, I actually have a follow-up question for you because there has been a little bit of talk about something you just brought up, the naltrexone and bupropion, the combo of that, which is also, I believe goes under Contrave is the name?
Yep.
Okay, so there's been I've seen some studies on it as well as people talking about how it's actually helped them with fatigue. Can you make any comments on that or have you heard anything on that? I know I've seen some studies in fibromyalgia, but I've also heard from other autoimmune patients that they have found that it has actually helped them with their fatigue levels, which might then, if they're, less fatigued, they're able to be more active.
Yeah, no, totally. So bupropion is an antidepressant. It's also known as the brand name is Wellbutrin. And so that's the bupropion piece. So again, if somebody has depression or even like low levels of mood, then perhaps that piece of the combo drug might help address one's mood symptoms, and that could potentially impact energy levels, improving energy levels. And then naltrexone itself is kind of another treatment that's often used in things like alcohol use disorder, or opioid use disorder. And I think at low doses, there are some, again, I'm not an expert in this, so take this with a grain of salt, but I think there was some literature looking at low dose naltrexone for chronic pain. I believe, I could be wrong. But again, I think I wouldn't be surprised if there were people who are feeling better taking this combination of therapies because they do have secondary benefits on working in the brain to improve stuff like mood and maybe energy. But again, I have to admit I'm not an expert in that.
Well, when our mood improves, so does our energy levels.
Yeah, that makes sense. And the other thing I really like when you said earlier about it really is like an individualized decision, like you as a doctor are individualizing your advice to the person in the room with you. But when I mentioned that knee, being every 10 pounds of being overweight causes a lot of load on the knee, what's complicated is it's like the devil's in the details because if you have a lot of extra fat on, let's say, your leg versus a lot of muscle that is the weight, the mass of your leg, it's going to act differently to support the joint. We are always talking about on this podcast strength training. And like, I feel like someone's like, you're being paid by big strength training to promote strength training. But I've had a huge positive effect. And I'm familiar with the literature that strength training is important. But you might think, well, wait a minute, strength training is actually technically, you're going to gain some muscle. So you might actually gain a little weight from that, because all weight isn't created equal. When you have more musculature, you're reducing the load on the joint. So how do you help your patients think through this? I don't know, probably some more coherently than I'm saying.
No, I think that's a great point. Usually what I tell people is that when you build more muscle in certain areas, like for example, when you build more muscle in the quads and the hamstrings, like around the legs, if you have knee osteoarthritis, it can help better distribute the load in the joint itself. Or I almost say, this is overly simplified, but I almost say it can help take off some of the load from the joint itself, because the muscles are helping move the joint in a healthier way and taking on some of that load in a sense when they're contracting in a healthy way. So I kind of tell them that the strengthening of the legs can essentially offload and help the knee joint itself function better.
That's beautifully said. Unfortunately, we do have to pay attention in science and physics in high school to remember some of these basic physics lessons. And yeah, I think just we're getting to the conclusion part, believe it or not, although I think both Eileen and I would love to talk to you for hours because you have such knowledge in this area. You alluded to a few studies already that are currently maybe underway. Are there any other exciting or groundbreaking research projects underway at the Arthritis Research Canada that you'd like to highlight?
There's so much amazing work that's being done at Arthritis Research Canada. And so to pick amongst all of my colleagues' amazing work would be really challenging. So instead, maybe what I'll do is, I don't think this is the most groundbreaking work, but I'll just tell you briefly about what I'm doing. And that way I don't have to pick amongst all the other stuff. So I'm currently doing my PhD, and essentially what I'm looking at is, I'm looking at the safety and effectiveness of semaglutide, or again, for people who don't recognize the generic name of Ozempic or Wegovy, and people who have inflammatory arthritis. So I'm studying people who have rheumatoid arthritis, axial spondyloarthritis, or psoriatic arthritis. And we're looking to see, based on existing administrative health data, whether people who get semaglutide for their diabetes, whether or not it helps their inflammatory arthritis. And what I mean by helps is whether they're less likely to have flares of their disease that require increases in therapy. So we know that when people have worsening disease, say rheumatoid arthritis, they often have to have increases in things like either you get prednisone added on short term, or your disease modifying agents get upped, or you get switched to a different drug. Maybe they add a biologic, maybe they add methotrexate. And so we're trying to see whether those additions are less likely if you're on semaglutide. Does this drug help keep your disease under control? That's part A. And then part B is, we want to see if it's safe in people with inflammatory arthritis. So we're looking at things like, are people more or less likely to go to the hospital for gallbladder attacks or for pancreatitis? Or are they more or less likely to go to the hospital with suicidal ideation or severe depression? Because there have been some concerns around mood with these drugs. There have been concerns around gallbladder attacks and pancreatitis with these drugs. So we wanted to look at some of those areas that have been brought up and see how they affect people, specifically with inflammatory arthritis, who often have been understudied in these GLP-1 trials to date. Again, this is just my work.
No,
There's so much amazing work. I just thought it'd be easier to talk about my own.
well, that's definitely the number one question on people's minds when this comes up in my audience, online and in the support groups that I lead. So people really want to know, what is the effect? Is there any reason people with inflammatory arthritis shouldn't take these meds specific to our population? So I think it's wonderful that you're doing that. And where do you recommend people go to learn more? I know that we mentioned the Arthritis Research Canada site. Do you have any links you want us to direct people to, like your own, LinkedIn, or do you have social media, or how should people find you?
Fair. I would say I don't really have much of a social media presence, if I'm being honest, but Eileen and I worked on a webinar together. This also lives on the Arthritis Research Canada website. But in September, we did a webinar on arthritis and weight. And so I gave about a 20-ish minute presentation. And then Eileen and I did a moderated Q&A where people were able to submit their questions. And then we also collated a bunch of resources, a bunch of websites, studies, references to other helpful resources like Obesity Canada's website, the Physical Activity Guidelines for Canada, things of that nature. And it's all on one page. So I would say that would be a great starting point. That link to that webinar and all the resources with it.
Thank you.
Absolutely. And even though talking about weight is such a difficult topic, and I didn't exactly want to do it, but I just felt like it was such an important topic. So I was really excited to be the patient partner in the video, but also not excited for, what's going on. But, it's so much information there, and I've been using a lot of it in my life lately and going at my own pace. So I really, really highly also recommend that informational page because it's not just the webinar, there's so much more. But in wrapping up this episode, because I know that there is so much more information and we can go on a lot more, but in one sentence, what is the most important takeaway you'd like someone to take away from this episode?
Okay. It'll three-part sentence. It'll be one sentence though, with a few commas. Okay. I would say obesity is a chronic disease, but it's not a person's fault and is treatable. So I'd say that's three parts. Chronic disease, not a person's fault, treatable.
Yeah, that's a very good sentence, actually. Three key points to a very impactful sentence. So again, thank you so much for being here and giving us all your wisdom. It's been an absolute pleasure once again getting to work with you and highlighting the important work that you are doing.
Yes, and this concludes our episode of Rumor Has It. And make sure to thank you all again so much for listening, and be sure to check out the full show notes on the Arthritis Life website, myarthritislife.net, where you can see also a full transcript plus a video of this conversation if that's your learning style.
And we would also love to hear what you think about this episode. Shoot us an email or comment on our social media pages and let us know. And if you have any topics you want us to cover, we definitely want to know about it.
Absolutely. All right. Thanks again, Dr. Carabit-Cavellia. We'll see you later. Bye-bye for now.
Thank you so much for listening. This podcast is supported by Room to Thrive, an educational program I created to help empower you to live life to the fullest with rheumatic disease. In the program, you're going to learn evidence-based tools for managing all the ways rheumatic disease affects your life. And my goal is to help you go from overwhelmed to confident, supported, and connected in a matter of weeks. You can go through the pre-recorded modules on your own in the self-paced course, or you can take the course along with a robust support group of new arthritis friends to support you and cheerlead you along the way. Learn more in the link in my show notes, or you can always go to www.myarthritislife.net. And if you like this podcast, I'd be so honored if you took the time to rate and review it. I also encourage you to share it with anyone you know who might benefit from it. I also want to remind you that you can find full transcripts, videos, and detailed show notes with hyperlinks for each episode on the Arthritis Life website, plus full episode videos on the Arthritis Life YouTube channel. If you have any ideas for content for future episodes, or you want to share your story on the podcast, please send me, Cheryl, an email at info@myarthritislife.net. I can't wait to hear from you, and thanks so much again for your time.